My name is Tran. I am a medical student at Texas A&M working in the lab of Dr. Rose Khavari at Houston Methodist Hospital, and I will be presenting the preliminary results of using a novel, non-invasive, and individualized cortical modulation device called Transcranial Rotating Permanent Magnet Stimulator in improving voiding dysfunction in female multiple sclerosis patients. This project is funded by Dr. Khavari's K23 awarded by the NLUTD. Voiding dysfunction, characterized by incomplete bladder emptying and urinary retention, is very common in neurogenic patients, including multiple sclerosis, and can negatively affect the quality of life. Currently, the only therapy with moderate effectiveness for voiding dysfunction is catheterization. For this study, we want to shift the treatment focus for voiding dysfunction from the bladder to the brain. We propose a non-invasive treatment by modulating cortical regions involved at voiding initiation using a device called the Transcranial Rotating Permanent Magnet Stimulator, or TRPMS. TRPMS is very similar to TMS, or Transcranial Magnetic Stimulator, a device most of us are familiar with that delivers magnetic field to the cortex to modulate neurons at a limited cortical area. However, since the brain control of the bladder involves multiple regions, TRPMS offers the advantage of being able to modulate multiple regions at the same time. The device is portable and controlled by a smartphone, therefore it has very promising potential for future at-home use. Here are the cortical regions we modulated. We stimulated regions that have been known to be activated at voiding and voiding initiation, including the right inferior frontal gyrus and dorsolateral prefrontal cortex, and inhibited those that are involved in pelvic floor contraction to facilitate pelvic floor relaxation and allow for urine passage, including the supplementary motor area and the right middle frontal gyrus. For each treatment session, stimulation would last for 40 minutes and inhibition was 10 minutes, and patients underwent 10 treatment sessions. To assess the therapeutic effects of TRPMS, we looked at two outcome measures. First is the change in brain activation via blood oxygen level dependent, or BOL signals, and second is clinical improvement using non-instrumented uroflow and validated questionnaires regarding bladder symptoms, and we compared these at baseline and post-treatment. Here are the inclusion and exclusion criteria. We included adult females with clinically stable MS and bladder symptoms. For this study, the criteria for voiding dysfunction is those who have either percentage of post-void residual over bladder capacity of more than 40%, fall below the 10th percentile on the Liverpool nomogram, or perform self-catheterization. I'll quickly walk through the process of setting up the device. First, we perform head measurement, which allowed us to identify the brain regions of interest later on. Patients then enter the scanner, where we perform 3 to 4 cycles of bladder filling and emptying while recording both of their functional MRI images and urodynamics to monitor their bladder during the image acquisition. Based on patient's brain anatomy and activation at the time of voiding initiation, we then identify the regions we want to modulate on their MRI scans and then on the treatment cap, and set up the microstimulators on the treatment cap so that they align with these regions. The treatment is therefore individualized for each patient. 10 patients completed the treatment for this pilot study, and here is the result for the first outcome measure. We took the average BOL signal of all 10 patients at post-treatment, which represents the brain activation, minus the average BOL signal at baseline. Red means there is a significant increase in activation after the treatment. Blue means a significant decrease. So after treatment at strong desire to void, we saw an increase in activation in modulated regions and regions that have been known to be activated with increasing bladder sensation, including the right inferior frontal gyrus, supplementary motor area, and thalamus, and decreased activation in the cerebellum, suggesting a more readily lifted micturition reflex in preparation for voiding. At voiding initiation, we saw an increase again in the right inferior frontal gyrus, which is one of the regions that we stimulated, along with other regions associated with bladder function like the cingulate, temporal gyrus, cerebellum, and thalamus. We also saw decreased activation in the hippocampus, which suggesting patients were making a more conscious attempt to initiate voiding. These changes in patients' brain activation were also reflected in clinical data. we saw a significant decrease in percentage PVR over bladder capacity, which is one of the criteria we use to define voiding dysfunction, and also significant decrease in post-void residual as well. Voided volume and maximum velocity also increased, although with no significant difference. With validated questionnaires, lower scores indicate an improvement in symptoms. So we saw an improvement in almost all of the questionnaires, with significant improvement in the neurogenic bladder symptom scores, which contains both storage and voiding symptoms. When we zoomed into only questions in subscore regarding voiding symptoms and quality of life, we also saw a significant improvement. With these results, we concluded that TRPMS might have helped increase the strength of connectivity of the voiding network, and therefore was able to increase activation not only in the modulated regions, but also in other cortical and subcortical regions involved during both storage and voiding phases. These changes were reflected in clinical improvement, specifically improvement in bladder emptying, both objectively through uroflow and subjectively through validated questionnaires. For the future, we would like to compare the functional connectivity of the brain voiding network at baseline and post-treatment, in addition to the brain activation that we already looked at, and also determine if there's any baseline clinical or neuroimaging factors that could predict the treatment response to TRPMS. We are also in the planning stage for a larger sham-controlled clinical trial to further confirm the effectiveness of TRPMS. I would like to thank my PI, Dr. Khavari, my mentors, and many other people on our research team for their guidance and mentorship throughout this project, and thank you for listening.